I'm pleased I'm in the office right now, and I'm joined by Dana Robinson, our clinical practice nurse, Laura Silver, our dietitian, Kelsey Labella, our PA. And on Zoom with me is Dr. Sundar, who is one of our medical oncologists, an expert in peritoneal metastases and appendix cancers. And so, we thought this would be an informative session, and perhaps we'll leave plenty of time for Q&A and any burning questions that you might all have that weren't answered previously. And so without much ado, I'll have Dr. Sundar start off for us, who's going to talk a little bit about precision medicine and appendix cancers.
Thanks, Dr. Thurag. It's really great to be here, and thanks everyone for dialing in. So as Dr. Thuraga mentioned, I'm a medical oncologist and physician scientist. Most of my work is looking at mechanisms of metastases, of how a tumor starts at a primary site and then moves on to the other sites, particularly for patients with appendiceal cancers, is the idea that the tumor starts in the appendix and moves on to the peritoneum. And that's kind of my area of interest and research expertise. And I'm going to share with you a little bit of my work. As a bit of a background, as a GI medical oncologist, I treat patients across the entire GI spectrum, from gastroesophageal cancers to colorectal cancers, as well as appendiceal cancers. So some of the work I'm going to show is going to spread across the GI spectrum, but still going to be very relevant to folks with appendiceal cancers as well. These are my disclosures. So I think as a medical oncologist, one of the things that we start thinking about is what are the processes that are involved in a tumor starting in the primary site, like the colon or the appendix, and what are the kind of processes that these, or the characteristics that these tumors need to acquire in order to be able to spread from the primary site to other organs. For example, what does a tumor need to do to be able to leave the colon or appendix and head out to other sites? Again, for appendiceal cancers, the way a tumor spreads to the peritoneum is probably going to be quite different from the characteristics that a lung tumor, for example, needs to acquire to go into the bloodstream and spread out to the brain. And for us to now start thinking about the way different tumors acquire different characteristics to spread out is something that we're quite interested in. Separately is also this idea that as these tumors are subjected to different types of treatments, chemotherapy and other sorts of treatments, that there are different ways in which these tumors change, and that might need to be factored into the next sets of treatments that we're offering these patients. And so one of the things that we are particularly interested in is this idea that is the process of metastases spreading from the primary site to the metastatic site, are they just random? Is it just as simple as the tumor fell off the appendix and ended up in the peritoneum? Or was it a selected process? Were there actually specific characteristics the tumor needed to acquire in order to land there? Or is it just a mix of both? And that's something that we have also been studying. And specifically for the purpose of metastatic cancer to the peritoneum is the concept of transcoelomic metastases, which essentially involves the primary tumor either in the stomach or the colon or the appendix, leaving the primary site, going through the peritoneal cavity and then landing out here. And this ability of these tumors to actually have special qualities, the kind of malignant, the kind of growth factors and other things that are there within the peritoneal cavity that help support the movement of these cells into the peritoneal lining itself, and the kind of qualities that the cells need to acquire in order to catch onto the peritoneum and then grow are what is essentially what we've been studying. And I'm sure most of you have already seen multiple slides in a similar vein of the peritoneum actually being two parts. One is the layer that covers the different organs, or what we call the visceral peritoneum, as well as the part that lines the abdominal lining itself, or the parietal peritoneum. And that's kind of the layer that, or the characteristics of the peritoneum that we're interested in, on what are the features that it has in order to be for these tumors. So this was a study we published last year, which essentially mostly focused on stomach cancers and looked at whether these tumors that spread to the liver, the stomach cancers that had a propensity to spread to the liver, were they different from stomach cancers that spread to the peritoneum? And what we were able to show quite clearly was that the characteristics that the peritoneal the tumors that had the propensity to metastasize to the peritoneum looked actually quite different. The gene expression programs that these tumors were acquiring were actually quite different compared to the ones that metastasized to the liver, for example. And not only was the qualities or the characteristics of the tumor in terms of the genes that they were expressing, but also the different kinds of other cells, or what we call the tumor microenvironment, which is the immune cells, the stromal cells, the other supporting structural cells around the tumor cells, were actually quite different between the tumors that were spreading to the peritoneum compared to the ones that were spreading to the liver. And the other part that we were quite interested in is we are looking at multiple therapeutic targets, both in appendiceal cancer as well as other cancers. And are these targets actually different if we tested the appendix or the stomach, for example, in this study, versus the same expression of the target in the peritoneal tumors? And in this study, we showed quite clearly that a lot of the therapeutic targets actually had different expressions in the primary tumor compared to the peritoneal tumors, which might explain a little bit about why these drugs work well in certain settings, but may not work as well if they're spread to the peritoneum. And for example, in this, the Claudin 18.2, which is an important target for gastric cancer, actually has a lower expression in the peritoneum, and therefore giving these drugs systemically may be less effective, and we might have to think of giving these drugs intraperitoneally, for example, in this sort of situation. And we had a similar study that also, apart from gastric cancer, we had a similar study in colorectal cancer as well. This was a separate paper that we published just a few months ago. A very similar sort of story, that the characteristics that the tumors acquire in colorectal cancer that spreads to the peritoneum is different. But one of the interesting things in this paper was that we actually identified a therapeutic target in the malignant ascites within these tumors that we are now trying to target, which might be one of the catalysts for the process of the metastases from the colon to the peritoneum. So this is just ideas that we are able to actually target these pathways that we are picking up through these kind of genomic studies that we're performing on these patients. And the last bit is, while a lot of these studies that we have shown is great for the research purposes, bringing this into the clinic has been a little bit more challenging. And this was, I'm sure you've seen similar sort of approaches in which we give intraperitoneal therapeutics. In a separate sort of study that we did, we actually looked at combining one of the intraperitoneal therapeutics called HIPEC with pressurized oxaliplatin to try and change the immune microenvironment of the peritoneum so that systemic immunotherapy might work. And in this clinical trial, we basically were able to show that by introducing the HIPEC and changing the microenvironment of the peritoneum, the ability of the immunotherapy to work was a little bit more effective. Of course, this is a very small number of patients, and the trial itself was a hypothesis-generating trial, a proof of principle trial, rather than strongly recommending that this is the way that all patients need to be treated. So I would encourage some caution in interpreting some of these data. But the truth is, we did have patients who typically would not have just responded to immunotherapy alone, but actually responded pretty well with the HIPEC and the immunotherapy. This is a patient who had a molecular profile that suggested that they would not respond to immunotherapy if you look at the CPS score of 0 here, but they had high peritoneal burden, and by the end of the second cycle, their PCI scores had actually dropped quite a bit and didn't have as much disease that was seen. And that's kind of my pitch over here, and I'm going to stop.
Thanks, Raghav, for that. I think, I think the key part that, I think hope all of you understand, we're very fortunate to have recruited Dr. Sundar, who's now been here with us for about a year, and has a particular interest in how cancer spread to the lining of the belly called the peritoneum. And we know appendix tumors spread remarkably to this. And so we have some incredible joint research as well as the opportunity for therapeutic targeting of some of this peritoneal spreading. And I hope you all enjoyed listening to that. I don't see any questions in the audience. And so if that's okay with all of you, we'll just kind of move on to our next presentation. Our next presentation is going to be from Kelsey Labella, who's going to talk about
operative
considerations for HIPEC.
Hi, my name is Kelsey Labella, and I'm a physician assistant with the Surgical Oncology Department at Yale. I'm going to spend a little time today talking about different factors that play a role in surgical decision-making. I'll speak briefly on general considerations, then on oncologic considerations, and then focus primarily on the use of ctDNA as well as chemosensitivity testing. Patients with peritoneal disease have a lot to consider when determining if surgery is their next step. Some general things to consider include different patient factors. This includes things like performance status, comorbidities, nutritional status, frailty, and psychosocial support. There's also different surgical risks to take into account. This includes things like the risk of anesthesia, expected morbidity and mortality of the surgery, and the overall expected recovery time. Lastly, you want to consider alternatives to surgery as well. This includes things like systemic therapy, radiation, ablations, different trials. You want to make sure you've explored all of your options, and then also go over the overall goal of the surgery, whether the surgery is being done for curative intent, diagnostic purposes, or palliative reasons. There's also oncologic factors that are considered when deciding for surgery. This includes tumor biology, which takes into account the aggressiveness of the tumor, tendencies to spread, likelihood of recurrence. And then you also want to think about the disease stage. So whether the disease is localized, oligometastatic, meaning it's spread to a couple spots, or if it's widely metastatic. Resectability plays a big factor as well. This is generally determined based off the PCI score, which you'll see outlined in the bottom right corner there. And then lastly, you want to look at the overall response to the neoadjuvant therapy that you've been on. So that's typically your imaging, your CTs, MRIs, PET scans, as well as tumor markers, and then the use of ctDNA. So Signatera is the testing for ctDNA, and it's just one of the many tests that the company Natera has available. ctDNA can be used throughout your entire cancer journey in many different ways. ctDNA stands for circulating tumor DNA, and it's a special type of molecular residual disease test that is designed using your own tumor. It can be used in the neoadjuvant setting to help measure response to therapy, and this is used in conjunction with your scans and tumor markers and just overall how you've been feeling on your chemotherapy. And then you ideally want to see these numbers going down in this neoadjuvant setting, or at least staying stable. It can be used after surgery as well in the adjuvant setting, and it can help decide the role for adjuvant therapy. For example, if you have positive scores after surgery or rising numbers after surgery, your medical oncology team may recommend the use of adjuvant therapy. And it's also used in surveillance, and it can help detect recurrence. And it oftentimes can detect recurrence before it's seen radiographically. So the initial testing does require tumor tissue, and it does require a blood draw as well. But the tissue is only needed for the initial testing, and this initial test design does take a few weeks to build. But once this is done, every subsequent blood draw has a turnaround time of about 1 week to get the result. It's also very convenient for patients as they do offer mobile phlebotomy for these blood draws, so you don't have to go anywhere to even get the testing done. And the testing is meant to be used serially, so we test patients about every 3 months, and we use it to correlate it with their scans and tumor markers as another marker to track recurrence, progression, overall surveillance. So the ctDNA levels can actually indicate the extensiveness of the disease as well. In our patient population, we observed that patients whose scores are low, meaning less than 1, often have only peritoneal disease. Once the score starts going up into the single digits, we'll often see nodal involvement. And then once we start seeing the scores getting even higher into the single or double digits, we'll see more organs involved, such as the liver or the lungs. We really like to focus on the trends before surgery, and we like to see the score going down. Ideally, we would like to see the score be 0 or negative before surgery. In our patient population, we often see that patients who have negative ctDNA before surgery have longer disease-free intervals than patients whose scores are positive. So if your score was negative before surgery, it's more likely to stay negative after surgery. And because peritoneal disease is so difficult to visualize on CT scans, and there's often more disease than what's seen radiographically, we use ctDNA as well to determine surgical candidacy, especially in patients who have oligometastatic disease where their disease has spread to other sites. And then lastly, I wanted to touch base on another test that we use called Trevera. Travera is a type of ex vivo drug sensitivity testing that uses live tumor tissue that we obtain intra-op either at the time of the laparoscopy or the CRS HIPEC surgery to assess chemosensitivity levels. It's beneficial in that it has a very fast turnaround time of about 72 hours. To the right of the screen, you'll see an example of a result, and the sensitivity is measured based on the mass response or the weight change of the cells in response to different chemotherapy drugs. So on the right, you'll see that each drug is given a score 0 to 100, and anything greater than a 50 is what is deemed sensitive. So we're currently exploring the use of this test in the adjuvant setting as well. There's a lot of things to consider when deciding if surgery is the right thing for you, but that's what our team is here to help guide you and make the decision for surgery when it makes the most sense in your journey. Thank you for listening.
Well, thanks, Kelsey. Our next speaker is Dana Robinson, who's our clinical practice nurse, who's going to be talking about preparing for surgery.
Hello, everyone. I'm Dana Robinson, the clinical practice nurse, and I'm here to talk to you about our patient and family resource guide. The guide. This is Peritoneal Surface Malignancy and HIPEC Treatment Patient and Family Resource Guide. This is a book that Evelyn and I wrote and edited, and we published it this year, and it went to the printer. It came out about the end of January, so that's when we started giving it to our patients. You will receive this book on your initial consultation along with some other educational materials. It's 16 pages long, but is chock full of information that you need, and that is specifically showing the assets of our clinic. A PDF form will be available soon, so we can send that to you when it comes out via MyChart if you want the paper copy and the copy for the computer as well. And you know, this book we're going to reference often when we speak to you and when we're with you either in clinic or on the phone. We're going to say, get the book, because that's our jumping off point. That's the point where we're going to start and finish, and that basically has everything you need to know for your journey here with us at Yale. Oh, like I said, what you need to know. So basically, we're going to start with our welcome to each of our patients, and we're going to share with you our vision and getting to know our team, because we have a pretty cool team. It's very dynamic. There are different disciplines that you're going to work with, and you'll get to know us really well. And most obviously, you're going to want to know about the specifics of cytoreductive surgery and the HIPEC treatment. We are going to go into some anatomical stuff. We have pictures, we have explanations of what parts of the surgery may be for you, what may not. It does, you know, go into some terms that we will explain as well. We talk about diagnostic tests you may need before surgery, immediately after surgery, and then going down in surveillance. The preoperative instructions are in there. We also talk in depth about what your hospital stay will look like and your discharge. We talk about bowel obstruction, what treatment options, if that comes up. There is a section on physical therapy, which we'll learn more about. And it has numbers and resources that are really going to be important to you and useful to you on this journey. We want you to feel empowered, informed, and at ease. And that's what this guide is, what this book is for you. We're going to encourage you and your care partner to read the guide, not once, but more like twice or 3 times, really synthesize the material and have a good picture in your mind of what the journey is going to be like. We're going to meet you at your level. Some of our patients have been on their journey for many years and have had many operations. Some, it's the beginning. So wherever you're at, we're going to start there and we're going to move forward. We're going to explain the details and answer questions. There's a section in the back for notes. If you just have some thoughts when you're reading it, or just questions that you want to talk to a provider, Evelyn and I, about, put them down there, and we are happy to help and go through and with a fine-tooth comb on what your questions are and get you the answers that you need. We're going to review with you at clinic when we meet you and over the phone. So there will be opportunities to communicate with each other, and also via MyChart if you have that set up. We will journey and guide you through surgery and beyond here at Yale. and we look forward to welcoming you to the beautiful state of Connecticut. Here's a little picture of a pizza because it is the pizza capital of the USA. So come and see us at Yale. We're super excited to take care of you, and we will answer any questions you have. So have a great day, and thank you so much.
Thanks, Dana. That was wonderful.
Thank you.
Our next speaker is Evelyn Afrier, who's going to talk about advanced directives. Evelyn is our nurse navigator at Yale.
Hi, my name is Evelyn, and I'm the nurse coordinator for our team. Today, I want to talk about the topic that most providers, patients, and families shy from discussing. And that is the topic of advanced directives. In our clinic, we see a lot of patients that are months and years into their cancer care journey, and no one ever discussed the topic of advanced directive with them. Usually, when you talk about it, patients will always say, oh, my oncologist told me to put my affairs in order. So, recently I was talking to one of our new patients about advanced directive like I usually do. And the first thing she said was, oh, this is about when they pulled the plug, right? I paused for a minute and I responded, no, this is more about empowering you to decide how to live if you are in a position where you could not make decisions for yourself. With this, I realized that there's a lot of education that needs to be done. And when Dana and I joined Dr. Turaga 2 years ago, one of the things that he talks about a lot with his patients is doing the advanced directives. And he has also encouraged his team to work on the advanced directive as well. So this Christmas, when my family comes home, my plan is to get mine done when they come home to start having this conversation with them. So I want to, dive a little bit into what the advanced directive is and how and who can do it. So advanced directive, I want us to think about advanced directive as not how we die, but how we want to live when we are no longer in a position to make this decision for ourselves. We are basically delegating someone we trust to respect our wishes when we cannot do so. So what is advanced directive? It is a legal document that allows a person to outline their wishes for medical care when and if they lack capacity to do so for themselves. There are two main forms of advanced directive. There's a living will and a healthcare proxy. A living will is a document that you provide that provides your wishes for medical care in final stages of medical illness in event that one becomes unconscious or unable to communicate for themselves. For example, do you want artificial nutrition? Do you want artificial ventilation, mechanical ventilation? Do you want your heart and lungs restarted when they stop? This document requires you to work with your attorney to outline the details, and then you have that given to your medical providers. The healthcare proxy, on the other hand, is you appointing a trusted individual to make decisions on your behalf and to follow your wishes when you're no longer able to do so. So why do we need advanced directive? The main purpose of this is to ensure that one's medical wishes are respected and to guide your loved ones and healthcare providers when you are not able to do so. Who can sign it? Advanced directive can be signed by anyone who is 18 years and older in the state of Connecticut. And who cannot sign it? It cannot be signed by your healthcare providers. Usually we have patients that bring these forms to the office for us to sign. We cannot do that. It's a conflict of interest. an employee of your institution. So, if you bring it in, a social worker can assign it, the housekeeper can assign it for you. It has to, unless they are family members, and then that should be done outside of the hospital. Also, a government agency providing financial responsibility for your care, like a conservator, can assign your advance directive. And also someone who lacks capacity. So if you have grandma in a nursing home with dementia, she cannot sign your advance directive. So, in the state of Connecticut, so the healthcare, the advance directive, it varies from state to state. And so to ensure that your healthcare proxy is valid, sometimes it's necessary to create a new document that complies with the specific state laws, or you may have to do complete a new form for each state that you are in, receiving medical care, or a state that you frequently visit. In the state of Connecticut, the healthcare proxy or durable medical power of attorney does not require notarization, or however, it has to be signed by a witness, a patient, and be witnessed by 2 adult witnesses. So when do you need to have an advance directive? The answer is today. It's now. You don't have to be, be terminally ill or have a serious illness to have advance directive. Everybody over 18, should be able to do their advance directive. And, you just have to get it done. Sometimes these are difficult choices to make. And just like everything in life, we all make difficult choices. And this is going to be one of them. I had to make one difficult choice this year when our team was riding closer to free for Yale Smile Cancer Research Fund. And last year our team rode, and I was not able to ride with them because I've never ridden a bicycle before. I rode a little bit when I was in my 30s, and I didn't enjoy it, and that was about it. But this year I wanted to join my team. This was a challenge. It was very difficult for me, but I had a lot of support with my teammates, and we rode and raised funds for Yale Smile Cancer Research. So get out there and have fun, enjoy life, and get your advance directive done. Thank you.
Thank you, Evelyn. And obviously your journey of that bicycle ride resonates with many of us, about making difficult decisions and just doing it. So thank you for that. Our next speaker is Laura Silver, who's going to talk about eating for prehab and surgery.
Hi, my name is Laura Silver. I am a registered dietitian here at Yale, and I am a part of the cancer care team. When you come here for a visit to see Dr. Taraga and the rest of this amazing team, you also benefit from nutrition services. And I work closely with patients before and after their surgery. And I want to share some information and some slides with you now. And today specifically, we're focusing on eating for prehabilitation or prehab, and really giving you that good foundation going into surgery. So nutritional prehabilitation or prehab, I think of it really as a strategy and a mindset, so that you have a chance to be proactive and to prepare and to really practice for surgery, because surgery, if you think about it, is a major stressor. There's physical stress, there's psychological stress, and we really want to help you prepare and give you a good foundation for that. While I would love to have more time to work with you before a surgery, even if we're just talking about 1 or 2 weeks before surgery, that does something that matters, and it's worth doing. So it's worth paying attention to your nutrition, even if you just have 1 or 2 weeks to focus on it before going into surgery. There's a lot of good research when it comes to nutritional prehab and the relationship between how your surgery goes and improved outcomes after surgery. And I'll just say, you know, there's been many studies that can show the length of stay can be reduced by at least 2 days when folks that are coming in malnourished are able to focus on their nutrition prior to surgery. And we also see that combined nutrition and exercise prehab programs can really decrease medical complications after the surgery by at least 40%. So there's a lot of good studies to support this focus. So there are many goals that you can be thinking about, many things that you can be practicing leading up to a surgery. It's true that for many folks heading into a cytoreductive surgery with the HIPEC, typically a high calorie, high protein menu will be appropriate for you. But this is where it's really good to work with a registered dietitian so that they can really personalize and tailor the advice and the recommendations for your medical history and for what you have going on. And I do say high calorie carefully here. It's often thought of as a bad word for us, right? We're often taught to stay away from high calorie foods, or that we shouldn't have them or we can't have them. But remember, there's a lot of different ways to eat a high calorie menu. There's a lot of healthy ways to do it. And especially if you have experienced weight loss heading into surgery, then it's actually really important to make sure that you're getting enough and even a little extra when it comes to calories and energy, as well as protein to prepare for surgery. We also want to give you a chance to practice the habits that you're going to need to use after surgery to make sure that you heal and get enough nutrients. And that can include eating and drinking on a schedule, small amounts, not big meals, but taking small sips, taking small bites, and doing that on a schedule, whether you feel like eating or not. That's really important because unfortunately after the surgery, it's really common for people to not have much of an appetite and for you to fill up very quickly, even though you've eaten only a small amount of food. You might feel very full very quickly. So we're preparing you for those things. We also will talk and coach you through ways to be, snacking between your meals and kind of more of a grazing approach to eating as opposed to sitting down to large square meals. And that can be a big change for a lot of us. And we really want to help you make the most of what you're eating and drinking whenever you can. We want you to look down at what's in front of you, in your cup, in your bowl, on your plate. Okay, can I add a little more protein here? Can I add a little more nutrition? And fruits and vegetables are a big part of that. There's some really important vitamins and minerals that the more we can sneak into your diet in the week or two, at least before surgery, it makes a difference and helps you to really make sure that your levels are at an optimal level heading into surgery. Sometimes we do have to change how you're eating fruits and vegetables, just eating them in a different way. For example, if you've been on chemo prior to surgery and maybe you've been struggling with diarrhea, or maybe you have a history of bowel blockage or obstruction, or you're at high risk for that. In all of those cases, we will typically recommend a gentler, easy to digest, low fiber menu. And in that case, you can still eat fruits and vegetables, but you have to change how you eat them. For example, cooking them first, removing the peels and the skins and the seeds. And there's a quick tip down here below that might be new to you where, really conveniently you can take canned vegetables, like totally 100% canned pumpkin puree or pureed butternut squash. And that can be something that you incorporate into a lot of different foods, sauces, soups, smoothies, hot cereal. And that can be a way to sneak in some fruits and vegetables in a different way. So if you're thinking about how much protein exactly do I need heading into surgery, well, this is a general recommendation since I'm talking to you all as a general audience. But remember, again, working with us, we would give you more personalized recommendations here. So think of your weight in pounds and then take about half of that. And that should be the goal for, really should be your minimum goal when it comes to protein on a typical day in grams. So for example, if I weigh about 200 pounds, then I want to cut that in half to 100. And then my goal is about 100 grams of protein throughout the day by the end of the day. What I like about some of the quick tips here that I'm sharing is that they are examples of strategies that you can use to sneak in protein without dramatically increasing the portion of food that you have to eat. because I know there can be a real limit to that. And it's not realistic to just expect someone to just eat more. We have to get more creative than that, and we have to find ways to sneak in protein and make the most of what you're eating and drinking, even if it's just a few bites. And all of the ideas shared here are would also be pretty gentle and easy to digest. Also, if you're on that lower fiber, easy to digest menu too. So lots of different ways to do this. There's more and more research now available about pre-surgery shakes, or you might have heard of them as immunonutrition shakes. And the question, should I drink a pre-surgery shake? The answer is probably. Now, not everyone can do this for various reasons, but if it's available to you and you can, I would encourage you to talk about it with your team and consider it. So it's basically the addition of certain immune boosting nutrients to in the form of a comprehensive shake. And it's usually got a good dose of protein in there as well. And there's good research to support that finishing one shake twice a day for at least 5 days while you're on a regular diet before surgery. So that's not counting the bowel prep day prior to surgery. There's good research that routine can improve your recovery time after surgery and reduce complications related to the surgery. And then quick ideas of when you're thinking about what to have as your last solid meal of the day prior. It's usually the day before surgery, right? Because the day before surgery, you might be busy doing a bowel preparation of some sort. Everyone's a little different with that. But remember that the last solid meal you're having should count as a lighter, easy to digest meal. Generally speaking, that means to stay away from fried food, especially greasy food, rich food. And I would also say stay away, for the most part, from raw vegetables. Raw vegetables can be great for you, but they take a lot of work to digest. So cooked vegetables would generally be better tolerated and better agree with you. There's a lot of breakfast ideas on this screen. I think breakfast for dinner can be a great approach, but it's not the only way. So lots of options, but generally speaking, lower in fat and fiber and a relatively balanced meal is a good last meal prior to surgery. We have lots of resources to share with you when you come here when it comes to nutrition and recipes and, exploring other recipes and getting some good variety. We have lots of guides and tips to share with you here. And I want to end with this. I saw a new patient recently, actually earlier this week, and they told me, of all the people that they were expecting to see at their visit here, they were most scared to talk to me. And I think that can be really common. Dietitians can get a bad rap, right? We have, there's a lot when it comes to our relationship with food, and it's really a lifelong relationship that we all develop with eating and with food, and we all may have different histories when it comes to dieting and weight gain, weight loss. So remember that that's all part of the context when we're talking about this, and that's why I think it can be really beneficial to think about the psychological side of preparing for surgery and really preparing yourself and exploring other resources. I'm often recommending there's a variety of guided imagery and guided relaxation exercises that you can do. You can find a lot of them online for free. And that can be another really important part of your prehabilitation process to prepare you, mind, body, and spirit for a surgery like this. Thanks so much for your time, and I look forward to meeting with you.
Thanks, Laura. That was wonderful. I can't imagine anyone being scared of meeting with you. But that was great. And I know there was a chat comment before about the guides for prehab for surgery for the CRS and HIPEC. But I think if you'd like our nutritional guide as well, we're happy to share that with you. So feel free to shoot an email to Kelsey or me. And so our last speaker for this session before we go into Q&A is Scott Capozza, our physical therapist, who's going to talk about what is prehab and is it for me?
Hi, everyone. My name is Scott Capozza, and I am a physical therapist at Smilow Cancer Hospital at Yale Cancer Center and Yale New Haven Hospital. And I am going to take the next couple of minutes and talk to you about prehab from the perspective of a physical therapist, but also answering the question, what is prehab and is it for me? And so you might be wondering, well, what's a physical therapist have to do with prehab, and why is a physical therapist involved in this process? Well, I think it's important, first of all, that a physical therapist meets you where you're at. So, if you're coming in and you've already been through treatment, so if you already received chemotherapy, maybe you've already had a surgery or two, you may not be in your best shape. And so it's important for the physical therapist to know this, to know where you are coming into your consult with your doctor, to make sure that they're able to devise the most appropriate program for you. And then I think one of the most important things that we can do, besides obviously instructing you on exercises, is really providing education and resources, especially if you might be traveling to some place that's not close to home for your surgery. So you might have your surgery at a large medical institution, but you live 2 or 3 hours away. So it might be upon the physical therapist's job to try to find you a physical therapist who's in your area. That way, the physical therapist can connect you with somebody, and you can continue your rehab with somebody who's much closer to home. And I think it's also important that physical therapists, can be an advocate, can be one of the many advocates that's in your corner. And I think it's so important that as you initiate your plan of care, that a physical therapist is part of that team. So that way, everybody on the team, from the doctor to the nurses to the dietitian, social workers, whoever is on your team, everybody has a sense of where you are and where you're coming from, so they know how best to meet your needs. And so what a physical therapy evaluation might look like, I always tell my patients, don't worry, I'm not going to make you flip tires and swing sledgehammers, but I do need to get an understanding of what are your physical impairments at that time and how that might be impacting your quality of life. So are you experiencing chemotherapy-induced peripheral neuropathy from prior chemotherapy? Are you in pain? Are you tired? Are you just overall deconditioned from prior treatments or prior surgeries? And it's important to know any other relevant past medical history things. Do you have diabetes, or do you have cardiac issues? And I always want to know what's your current exercise routine, but also what do you like to do? Before you were diagnosed and before you started treatment, what did you like to do for exercise? Did you like to walk? Did you like to hike? Did you like to bike? So that's important to know, because if that's something you want to get back to, then that helps me develop goals to help you. And so the way that I'm going to assess this the first time that I would meet you as a physical therapist, I want to get a sense of your strength. I often will check everybody's upper body strength with a handheld dynamometer. I will also check your leg strength with a 30-second sit to stand, essentially a squat test from a chair. And I like to do some sort of cardiovascular assessment to get a sense of what is your endurance like. So I usually do either a 2-minute walk test or a 6-minute walk test. And then as far as what our physical therapy interventions might look like, again, it's very patient-centric. Yes, there's going to be a certain set of exercises, and some of the exercises might show some overlap from one patient to the next. But ideally, the idea of prehab is to get you as independent as possible. I want you to be able to do these exercises at home. So yes, I am giving you homework. I do want you to do your homework. And that can happen a lot of different ways. Again, if you live close to the medical facility where you're having your surgery, then you can have those appointments in person. If you are within the state boundary, you might be able to do telehealth visits as well. And the exercises are going to be a mix, working on strengthening, overall muscle strengthening, as well as cardiovascular endurance, stretching, and balance. Again, somebody who has neuropathy, then balance is really important that I'm going to be working on, because the last thing I need you to do in the middle of all of this is to fall. And I like to refer back to the American College of Sports Medicine exercise guidelines. That helps me guide a program that's appropriate for you. So I'm going to take these national guidelines, but I'm going to just distill them down, and I'm going to make them applicable to you, to the person who's sitting right in front of me. And so again, some of those exercises might look kind of similar from one another, but my big sense is that I want to work on core strength, proximal strength, shoulder strength, and hip strengthening to make sure that you are in as good of physical shape as possible going into surgery. And again, as I mentioned earlier, a lot of this is about initiating that continuum of care. So if I can see you in prehab and I get a sense of what is your baseline, it also allows you to form that relationship, to begin to form that relationship with your physical therapist, because then that physical therapist hopefully can follow you through treatment, can follow you through chemotherapy, can follow you through surgery, especially on the post-surgical side of things. So it's so important that you are able to start physical therapy early and be able to maintain and stay with a physical therapist, be able to do your exercises through surgery and post-operatively. Obviously, those exercises can change after you've had surgery, and that's why, again, it's so important to have a physical therapist there to be able to modify your program as necessary. But really, this is all about enhancing your post-surgical recovery. So thank you very much for your time. I appreciate it. Thank you again, as always, for having me, and I wish you all the best.
Well, thanks, Scott, for that, and thank you all for listening in. I know it's been a long day for all of you. I just wanted an opportunity for all of you to get to know our team and have the opportunity to ask any questions, or feel free to use our contact information to also reach out later. So we'll kind of pause for a few minutes, but we've been very interested in peritoneal disease and appendix tumors for a very long time. And I think we're excited that our group is growing, and we've recruited another colleague of ours who's starting in December, and our research labs are also up and running. And so hopefully we'll have some interesting updates to share next year with all of you. But we thank you all for your support and your attention today.